Hello guys, this is my latest videos about the pre-operative care. So thank you for subscribing my channels and keep inspiring me for my previous videos. So today I'm going to start the paper 2, that is POSG, Principal Practice of Surgery. That is the second part. So here the pre-operative care from the Reda notes, which is also called the Sala notes, also called the Reda notes, and so on, which is a complete lecture of MRCS description. So first of all, in the very most important topic, that is anesthesia and their use of scoring system. So here that is ASA, that is anesthesiology physical status scoring system. So in the previous exam I have seen two questions, the one question from the January 2023 and the May 2023, and also question come from the ASA scoring system. So let's start. So some patients don't know about the terminology and the what is going to do with their patients, and the doctors will counsel about the operative procedures along with the hazards. So we need to make a skill-based counseling to the patient. So first, this is the ASA grading system, and that is grade 1, 2, 3, 4, 5. So 1, that is normal patients like us, that is surgical pathology is localized when and there is no provocating factors or the systemic disturbance. Secondly, there is mild to moderate systemic disruption caused by the surgical disease process, so the underlying pre-existing disease, like previously a patient was diabetic or hypertensive, that is one kind of comorbid conditions, or the repeated attack of appendicitis or repeated attack of acute cholecystitis or acute on chronic cholecystitis sometimes. So that is regarded as a pre-existing disease, okay, that may be affecting the mild to moderate systemic disruptions, okay, that is the ASA grade 2. So in case of 3, that is systemic disruptions caused by the surgical pathology, that is most of the patient of the acute emergency, or some patients with perforation, or some patient with acute cholecystitis or appendicitis came with the stage 3 ASA grading system. So anesthesiologists mostly they need to solve or face grade 3 group of patient, and 4 and 5 was severe one, that is severe systemic disease, that is constant threat to life, like shock, okay. It is kind of you can say this is shock, okay. And the patient who is moribund and not will to survive without surgery, that is acute blood loss due to road traffic accident, or massive or strangulated bowel surgery, strangulated intestinal obstruction, or a patient with obstructive features of colon or gut. So if you do not attempt surgery, that patient will not survive, okay. So just remember these quotations: who is moribund, about to die, will not survive without surgery. Now what are the activities we need to perform before surgery, that is of the preparation of the surgery. So it may be differ to patients. So some patients are elective, that is a normal patient, they used to know their disease process, they know what is their problem, so they came to the hospital and admit to under operation or consultant, and the consultant will make an elective surgery. And another age group is emergency patients, so they require different preparation. So we need a small time period, we have to manage as early as possible, so we have limited time period, in that case we have to skip some investigations. We have to take decisions as early as possible, so quick. That's why in that group of patient the preparation pattern will be different. Now in case of elective patients, so we first pre-admission clinic address medical issues, that is history. Then we need to perform full blood count, urinary left, that is liver function test, bleeding clotting time, and the others. Urine analysis for urinary, pregnancy test if the patient is female and he don't know about the surgery, because there are some medications or anesthetic medication that we use which is harmful or teratogenic to the fetus. And the ECG chest X-ray, very good for, because it is necessary for anesthetic purpose as well as the cardiac status. Now there are other tests available for the preoperative preparation, which depends on the patient's fitness and the proposed procedure which will be done in case of operation. Here the risk factor of development of the deep vein thrombosis. So some patients will after the major surgery has a possibility to form deep vein thrombosis, should be assessed as early as possible, and the plan of thromboprophylaxis is formulated. Like you can say that pelvic surgery or fracture of the neck of the humerus or lower end of the humerus, and the aortic aneurysm rupture, or any kind of pelvic surgeries like colorectal malignancy surgery, hemicolectomies, APER surgery. So there chances of huge tissue loss or injury. In that case, a lot of thrombotic substance is released to the blood. In that case, a low molecular weight heparin or unfractionated heparin for a long time, or low molecular weight heparin for a short duration, we can use as a prophylaxis. Now there are some comorbid factors we need to remember before operation, like a diabetic patient have a greater risk of complications, so they should be kept on the first list, because diabetic or glycemic control or glycemic status is changing time period. So in that case we should keep a diabetic patient in the first list. Then the poorly controlled diabetes carries high risk of wound infection, that is diabetic ketoacidosis or uncontrolled, a patient with uncontrolled diabetes mellitus. Now the patients with diet or tablet controlled diabetes may be managed using the policy of omitting medication and checking blood glucose level regularly. Diabetes should be so here we need to take some precautions, because a patient with diabetes are sometimes they used to control their glucose level by medications, so we have to omit the medications and sometimes turn back to the parenteral insulin and maintaining the glucose regularly. So a tablet control diabetes must be using policy of omitting medications. Okay, so diabetes who are poorly controlled or who take insulin may require intravenous sliding scale. Potassium supplementation should also begin, because insulin is a substance which helps to take potassium into the cells. So there will be a hypokalemia in case of insulin dependent diabetes mellitus, so it will create another problem, that is cardiac arrhythmia or this kind of problems. So in that case we have to use potassium supplementations along with the insulin. So here the diabetic case should be operated first. Okay, first list. Now emergency case, to stabilize and resuscitate where necessary. Some patients we can stabilize and resuscitate, or some patient we don't, because there is limited time. Consider antibiotics which is needed and how they should be administered in from blood bank if major procedure planned, because there is a chances of huge blood transfusion. In that case we have to make blood arranged where the coagulopathies are present at the outside, like rupture of aortic aneurysm rupture, right? So we have to make another blood for transfusion. So don't forget to consent and inform relatives. Special preparation, that is thyroid surgery, vocal cord check. Parathyroid surgery consider methylene blue to identify glands. Yes, there are some special preparations because some patients with hypothyroidism or hyperthyroidism, so and that's why we have to manage first about the thyroid status. We have to know about the T3 T4 TSH and parathyroid gland status because and their secretions by methylene blue, because we have to know that where is the gland and is it functioning or not. We all know that parathyroid gland is very essential for calcium management, postoperative hypercalcemia or hypocalcemia, which is being managed by the parathyroid gland, and so their activity is also necessary to know. So surgery involving the thoracic duct considered cream. Oh yes, okay, thoracic duct has a very much chances for injury due to like any neck surgery or surgery to the apex of the lung. In that case there is a close relation of the thoracic duct in case of left side. In that case we can use cream for identify the thoracic duct for not being injured. In case of pheochromocytoma, we will need to alpha and beta blockers because pheochromocytoma can causes hypertension. Surgery for carcinoid tumor will need covering octreotide because octreotide will decrease the secretion of carcinoid tumor. Okay, now the colorectal cases, bowel preparation, especially left-sided surgery. So in case of colorectal surgery, bowel preparation is usually done in case of left side, and in case of right side we usually don't make bowel preparation, but it is a very good practice to have better bowel preparations, because after the bowel preparation the loops of bowel that is small and large intestine become collapsed, so there is very good chances of anastomosis and they reduce the chances of leakage post-operative period, so the healing will be so good. In that case bowel preparation is needed, and it also helps to reduce a lot of bacteria from the cut. Now the preoperative fluid management. So it is one of the important features by the NICE guidelines and fluid management, that is British Council's guidelines IV fluid therapy. So it should be remembered very good, because sometimes in the exam you will be asked which fluid is necessary, which fluid is the best one, and how many amount you should prescribe every time. So sometimes it has been asked. So Ringer's lactate or Hardman solution is used as a crystalloid for resuscitation or replacement of the fluid. Very good things. Is an isotonic fluid, and avoid 0.9% normal saline due to risk of hyperchloremic acidosis. So you can't use a lot of normal saline, but in our country I saw some doctors use normal saline randomly as the first fluid in case of diabetic person, but I think which can be changed because Hartzol is a very good fluid because it contains a lot of electrolyte along with potassium chloride lactate, but in case of normal saline it contains only sodium and chloride. so it can causes hyperchloremic acidosis, which is not mentioned or not practiced or not assessed, because ABG analysis in our country is not so good. But in UK you have to use Ringer's lactate or Hartmann, unless patient is vomiting. Yes, there should be a chance of use of normal saline if there is a chances of vomiting or gastric drainage. In that case you have to make stomach preparation or excessive resuscitation of the sodium chloride. In that case you can use normal saline. Use 4% of 0.18% dextrose saline or 5% maintenance fluid. Yes, DA or 0.18% dextrose is very good for maintaining fluid, because it contains only glucose and water. So when a patient is NPO, it will provide glucose support, and the body's own glycogen support will give additional energy from the liver, and the instant, that is glucose support, which is maintained by the DA. Now in case of adult, a patient needs 50 to 100 millimole per day sodium and 40 to 80 millimole per day potassium, and 1.5 to 2.5 liter of fluid is necessary per day. So sodium potassium is very important, you should remember that. And the patients of elective surgery should not be kneel by mouth not more than 2 hours. So starvation before surgery or NPO before surgery is not so encouraged. We will not use more than 2 hours kneel by mouth, unless there is a disorder of gastric emptying. Okay, it should be also known. Most of the person don't have any problem in the stomach. In that case we can allow fluid after 2 hours before surgery. Patients for elective surgery should be given carbohydrates drink 2 to 3 hours before. Okay. Yes, why? Some students can ask why, because if you use 2 to 3 hours, that is carbohydrate, post-operative outcome will be very good. Carbohydrate drink can be allowed 2 to 3 hours before operation. So we will use mechanical bowel preparation, avoidance of mechanical bowel, because if it is not necessary, if there is no chances of resection, anastomosis or any chances of bowel surgery, no need to make a bowel preparation. But if there is a chances of resection, anastomosis or gut related obstruction, we need to perform bowel preparation. During bowel preparation, simultaneous Hartmann solution must be used. So excessive fluid losses from the vomiting should be treated. Crystal potassium replacement, 0.9% sodium saline will be given if there is a hypochloremia. Okay, so vomiting should be treated with crystalloid and potassium replacement, and if there is a hypochloremia, we can use sodium chloride. So high risk patient should receive fluid and ionotropes. An attempt should be made to detect pre or postoperative hypovolemia using flow based measurement. If this is not available, then clinical evaluation is needed, JVP and pulse, etc. In blood loss or infection causing hypovolemia should be treated with balanced crystalloid colloid. A critically ill patient is unable to execute sodium and water, leading to 5% risk of interstitial edema. Therefore 5% dextrose as well as colloid should be given. Here there is a message, that is, in case of critically ill patient, those who are unable to excrete sodium or water, leading to 5% risk of edema, that is syndrome of inappropriate ADA secretion. If you use a lot of DA or dextrose in aqua, in that case there is a chances of edema or increase ADH secretion. So in that case colloid should be given. So here are some pre-operative intraoperative fluid management, that is sodium. It is not usually used, but in case of Hartmann, please remember potassium and the lactate 28. Lactate is present in case of Hartmann. That's why it is used in the shock patient. Recommendation for intra-abdominal intraoperative fluid management, which is not needed. This is not needed. This is not needed for the part A preparation. Intravenous access. A number of routes. So there are many routes which is given for giving fluids. The peripheral venous cannula is easy to insert for minimal comorbidity. That is PICC line, which can be used to provide TPN, which is irritant drug. So problem peripheral sites. So wide lumen cannula can provide rapid fluid infusions when properly managed. Maybe promptly identify the cannula easily reside. The problem related to their peripheral sites, they are unsuitable for administration of the vasoactive drugs like as ionotropes and irritant substance. So like peripheral venous cannula, which is very popular, like radial vein or intracubital veins. So we use actually the drugs which is water soluble, not so heavy. In case of vasoactive drugs, and TPN cannot be used by the peripheral venous cannula, so there will be unsuitable things. Those are. Now the central lines, that is CV line, insertion is more difficult. Most operator and nice advocate use ultrasound. So ultrasound guided insertion of CV line, central line is advised because it is more difficult to insert. So there may be a chance of coagulopathies, which leads to hemorrhage following iatrogenic arterial injury like subclavian artery here or the internal jugular vein sometimes be pricked. That's why coagulopathies can be happened. So in case of central line, there is a chance of pneumothorax because apex of the lung is present just behind the jugular vein. That's why if there is a chances of formation of pneumothorax or creating a pneumothorax. And the femoral line is easier to insert and iatrogenic injury easier to manage in this site of they are prone to high infection rates. So a femoral line is easy to insert, but there is a chance of infections. Intraosseous access. This is typically undertaken in anteromedial aspect of proximal tibia. So in case of proximal tibia, there is shin border, which is anteromedial aspect. So skin is very adjacent to the bones. That's why intraosseous can be accessed. So we can use give fluid or in chemotherapeutic agent to the bone marrows by the circulatory system. Another one is Tourniquet line such as Gronsgong and Hickman's line. A popular device for the patients with long-term therapeutic requirements, like patients with short bowel syndrome, where the ileum is mostly resected by or the necrotized by the mesenteric ischemia or mesenteric thromboembolic complications. That patient might need a long-term therapeutic management. In that case, we should use the Gronsgong and Hickman's line, which is popular. It can be kept for a long time, and therapeutic management like TPN or other nutritional supplementations or medications can be accessed through these two lines. So these two lines can be inserted by the ultrasound guided in the internal jugular vein, then be tunneled under the skin. A cuff of woven matrix is sited near the end and helps to anchor the device to the tissues. That is enough. So you should remember that long term process for the long term nutritions, Gross-Gong and Hickman's line is popular for giving fluids or electrolytes and nutritions. So PICC line, peripheral inserted central cannula, which is another very popular things. Popular method is central venous access, because they are inserted peripherally. They are prone to major complications like device insertion and conventional central line. So it is very expertise dependent also, like central like CV line, because in during the insertion there are chances of vein rupture, there are chances of making extracellular bleeding like hemorrhage can be occurs, but it is very popular nowadays other than these central lines. Now the atropine, which is a muscarinic receptor antagonist, it therefore inhibit the parasympathetic activity. It will traditionally used as a pre-medication of anesthesia, and it reduce the bronchial secretions, yes, and the salivary secretion as well, and bradycardia. From increased vagal tone or anesthetic inductions, because during inductions there are chances of bradycardia or reduced cardiac activity, or secretion can be raised by the salivary gland, also the bronchial secretion. So we have to use atropine to alter the parasympathetic activity, which helps in induction of anesthesia. So and their side effect is the pupillary dilatations and the urinary retention. Okay, so urinary retention and pupillary dilatation can be happen, but nowadays the use of atropine is going to reduce because of their withdrawal effect, or pupillary dilatation or urinary retention rate is huge. That's why doctors are trying to make some alternatives. Now the local anesthetic agents, so you have to know what are the agents which is used for local anesthesia, that is lidocaine, cocaine, bupivacaine, and the prelocaine. Okay, those are used for as a regional anesthesia or local anesthesia. So lidocaine, xylocaine, or lignocaine, very popular for local anesthetic, which is less commonly used in antiarrhythmia. So toxicity due to IV access, so we don't use IV because of the toxicity, so which increase the risk of liver dysfunction. So note, acidosis of the lidocaine is detached the protein binding, so it is that's why it is not used as IV, but to infiltrate the tissue, but not in IV use. So it can interact with the beta blockers, ciprofloxacin and phenytoin. Initial CNS overactivity and depression, lidocaine initially block inhibitory pathway, then block the inhibitory and inactivating pathways. So in case of cardiac arrhythmia, we should avoid lignocaine because it has a capability of CNS depression. In case of cocaine, so cocaine is limited use, so only in the ENT surgery. It is supplied for clinical use. Concentration is 4 to 10%, and applied topically in the nasal mucosa. It can causes marked vasoconstriction, which is an additional advantages, and it is lipophilic and will readily cross the blood-brain barrier. So it is systemic if it also cardiac arrhythmias and tachycardia. So you know about the cocaine because cocaine abusers, it can be a patient of you, so you should know the patient is on a cocaine use or not. So there will be chance of vasoconstriction, cardiac arrhythmia, or delusional problems, tachycardia. And but in case of medical use, we going to use in the cocaine in the nasal mucosa. But nowadays prelocaine is also used to control the epistaxis or bleeding of epistaxis. So bupivacaine, which is widely used as spinal anesthesia, that is, it has a much longer duration of action than lignocaine. Used for topical own infiltrations in the surgical procedures, long duration of action. So if you want a long duration of action, in that case you can use bupi or bupivacaine. So bupivacaine is less cardiotoxic and causes less vasodilation. So another latest things, that is bupivacaine is also used because of less cardiotoxic effect. Prilocaine is similar action other local anesthetics, beer block, very important. In case of caudal block or the peripheral finger block or beer block, that's why prilocaine is very much used for beer block, because it is a less cardiotoxic and the local infiltrations. So it is not for part 1, but part 2 examinations you have to calculate a patient of supposed weight in kg. So that patient need how much anesthetics for infiltrations you have to calculate. So on the other hand, in case of part A, so a patient with prilocaine or bupivacaine, how many doses is needed, because like in the normal plain dose 2, in case of added with adrenaline, that is red solution with 2, and lignocaine is 7, but plainly it is 3 milligram. So you have to calculate how much lignocaine with adrenaline is used for a scalp bleeding. So like 35, like 50 if a patient is 50 and 7 per kg, that means 50 into 7, 350, that means and per kg it is like 15 to 35 milligram lignocaine is used in that case. So here that kind of problem based question can be cited for part A exam. Now the effects of adrenaline. Adrenaline is also added as an ionotropic or effect, that is also can be added as local anesthetics. It prolongs the duration of action, that is red solution. It is contraindicated with the MAO inhibitors or monoamine oxidase inhibitor. The toxicity of bupivacaine is related to the protein binding, does not permit increase the total amount of bupivacaine. So adrenaline must be used with the lidocaine, but bupivacaine must not, because it is related to protein binding, and adrenaline will prevent bupivacaine for increasing the doses, which can be done with the lignocaine. Now we can see some total intravenous anesthesia, TIVA bola hoy, most probably it is been called the IV induction agents. So there will be the propofol, sodium thiopentin, ketamine and etomidate. So these are widely used. In case of propofol, rapid onset of anesthesia can be happened. Pain on the IV injections, rapidly metabolized with the little accumulations of metabolites, proven antiemetic properties. So we should remember that propofol has antiemetic properties. So it can be used to anti-vomiting activity. So maintain sedation, ITU total, IV anesthesia and for day case surgery. Propofol is widely used nowadays. In our hospitals, propofol is used. It is look like white solutions like a milk, and it's used for TIVA, that is total intravenous anesthesia. Can be done in IV and moderate chances of myocardial depression. And sodium thiopental ultra short acting anesthesia, extremely rapid onset. Marked myocardial depression can be occurs, unsuitable for maintaining infusions. It can be done in the first time, but maintaining must be done by propofol. So there is a little analgesic effect. So ketamine may be used for induction of anesthesia, that is dissociative anesthesia. Ketamine used as a dissociative anesthesia. Let me write it here. Dissociative anesthesia. Okay, has moderate to strong analgesic properties. Okay, moderate to strong. Okay, strong analgesic properties. Sometimes local anesthesia fail to provide adequate actions during operation. So to maintain the effect of spinal anesthesia, we have to administer ketamine for synergistic effect, because it has a strong analgesic properties. Produce little or myocardial depressions, making suitable agent for anesthesia. Sometimes ketamine can be used the patient who are hemodynamically unstable, like the patient with low ejection fractions, the patient with low hemoglobin percentage, or the patient with low systemic nutritional status. In that case, if the operation is emergency, we can use ketamine as a anesthetic agent. So there may be nightmares, patient feel nightmare because it is the dissociative anesthesia. Okay, so etomidate is a steroid derivatives. It a very favorable cardiac safety profile with a very little hemodynamic instability, and post-operative vomiting is common, may result adrenal suppression because it is steroid derivatives. So if we use etomidate, there is a chance of steroid adrenal suppression, Addison's disease, because it will suppress the steroid activity because it is derived from steroid. Okay, now this is the airway management. So airway can be managed by different ways, that is oropharyngeal airway, laryngeal mask, endotracheal tube, and tracheostomy tube. Here you can see endotracheal tube, and this is the laryngeal oropharyngeal airway maintenance, that is tongue depressors. So easy to insert and use, no paralysis required, ideal for short procedures. And the laryngeal mask widely used, yes, very important, very easy to insert. Device here for pharynx and the align scope for the airway. Poor control against the reflux gastric content, because it cannot prevent gastric content to come outside. Commonly used for wide range of anesthetic uses, especially day case surgery. We use it. Endotracheal tube for mostly the GA or the general anesthesia. It provides the optimal control of airway once cuff is inflated. A long term or short term ventilation for short and long term. Yes, this is the endotracheal tube for short term or long term ventilations. For like general anesthesia, we use endotracheal tube. So errors of insertion may result esophageal intubations, therefore tidal carbon dioxide will rise. Paralysis often required because due to for endotracheal tube we have to paralyze the diaphragm and the larynx also, because it can causes gag reflex, severe gag reflex by the glossopharyngeal nerve. That's the paralysis sometimes required for intubations, and higher ventilation pressure can be used sometimes. Tracheostomy very important for part B, not for part 1, but also we need to know something, that is Tracheostomy is used for emergency purpose like laryngeal burn, laryngeal edema, or in case of choking or cutting throats, or road traffic accident, or the burn patient, laryngeal edema, or any surgery to the larynx, or laryngectomy. That's why after that, or in case of tracheas like thyroid surgery, if any injury to trachea, in that case tracheostomy must be introduced. So work of breathing will be less and may be useful for slow weaning. Percutaneous tracheostomy widely used in the intensive therapy unit, and dry secretions and humidified air should be required because nose and the nasopharynx will act the humidifications as the air goes through the tracheostomy tube. That's why humidification process is hampered. In that case, the remaining portion of the trachea, carina, and the others bronchus should be dry. That's why humidified air is introduced in that case. Here are some muscle relaxants. So before GA, we have to introduce some muscle relaxant. So here the succinylcholine, which is widely used as a muscle relaxant because it's very short acting and no need to use any reversing drug because it acts 5 to 6 seconds or 1 to 2 minutes at lastly. Then patient, if you perform endotracheal tube insertion or if it failed, so no problem, succinylcholine will reverse. So depolarizing effects inhibit action of acetylcholine or at the neuromuscular junctions, and the fastest onset and the shortest duration of action of all muscle relaxants. Generalized muscle contraction prior to paralysis. So the adverse effect will be hyperkalemia, malignant hypothermia, and delayed recovery. In case of atracurium, non-depolarizing neuromuscular blocking drugs and duration of action is 30 to 45 minutes. So generalized histamine release on the administration may produce facial flushing, tachycardia, and the hypotension. So many things can be happen because atracurium is histamine. A lot of histamine is released because histamine sensitive muscle relaxant is atracurium. So you can see the facial flushing, tachycardia, and the hypotension. After atracurium use, facial flushing, tachycardia, and the hypotension. So not excreted by the liver or kidney, broken down in the tissue, then hydrolysis, reversed by the neostigmine. So neostigmine is very important here. Vecuronium, that is Vecur, which is non-depolarizing muscle neuromuscular drugs, which is approximately 30 to 40 minutes. So vecuronium is very much essential for maintaining the muscle relaxations during pre-operative period, which is not used for induction or starting the muscle relaxant, but also it can causes maintaining the muscle relaxant throughout the operative period. But during the introductions, we especially use succinylcholine for starting the intubations, which is also reversed by the neostigmine. So malignant hypothermia, which is a complications of succinylcholine, which is rare, not so common, but it happens sometimes because associated genes chromosome 19, not everybody will be affected by hypothermia. Those has the chromosomal defect, including the ryanodine receptor, which control the calcium release and sarcoplasmic reticulums. So the chromosome 19 defect with the people has a calcium disorders with the ryanodine receptor, that they will face the malignant hypothermia. Okay, 1 in 15,000, not so common. So causative halothane and succinylcholine. So management dantrolene prevent the calcium release from the sarcoplasmic reticulum. So it is not for everybody, because those who have a problem with chromosome 19 or the autosomal dominant disorders, they will face malignant hyperthermia as well. So this is our last topic, that is tourniquet. Tourniquet are used during surgery to minimize the blood loss and ensure the clear operative field. They must be correctly applied on the monitor. Not so important nowadays, because tourniquet is used actually in the limb lossing operation, like amputations or taking blood samples. We have to block the blood vessels or to clear the operative fields, to know the minimal blood losses. We use mainly apply the extremities. Most cases are inflated using pressure monitoring system. So post inflation, increase systemic vascular resistance, increase cerebral venous pressure, increase BP after tourniquet is established. Slower gradual increase of BP over time, induce hypercoagulable state, and slow increase in the core temperatures. So it is the usually questions of can be asked from the physiology or physiological portions. Okay, so systemic vascular resistance, increase CBP and increase BP. Post deflation, there is fall in CBP, BP and SVR, and increase the end-tidal carbon dioxides, fall in core temperatures, and raise serum potassium and lactate levels. Okay, so they are the contraindications. So absolute AV fistula and the severe peripheral vascular disease and previous vascular surgery, and the bone fracture or thrombosis at the site of tourniquet application. So these affected patients should not use any tourniquet to make. That's why tourniquet is something known to. And also tourniquet can causes local damage of the skin, muscles, and the damage of the underlying vessels and neuropraxia sometimes. If tourniquet is so tight, or if tourniquet is laid in the region for a long time, that's in that case local complications along with the other systemic complications also can be happen. So BP, CBP and the coagulable cells, and these CBP, BP and the SVR will be reduced after that is ischemic perfusion ratio. Okay, that is all about our today's presentation, or the first lecture about the principal practice of surgery, preoperative management and the anesthesia. So mostly this lecture usually known as the preoperative preparations, operative anesthetic hazards and their uses. And the next time we'll going to continue our next parts. So till then, watch my channels and like my videos and subscribe my channel also, and it will help your future MRCS journey, that is part of preparations. Soon I'm going to start the Bailey Lab book 2 or 27th editions, but some people will ask about the 28th editions, but I think 27th edition is enough, and there is some changes or recent changes in 28th edition that will be discussed later on in some new videos with limited extra which is given in the 28th editions other than 27th edition. So there will be a different or little change in the next book, and that will be discussed with one videos in each system. Thank you very much, and till then, thank you. Peace.